Good morning, afternoon, or evening, everyone, and welcome to today's TIRO by MD's webinar session. I'm Dr. Camilo Gonzalez Velasquez, and it's my pleasure to host this event. Today, we have an exciting and insightful presentation lined up for you, focusing on the topic of at the intersection of technology and clinical practice, a recent publication by the Mayo Clinic Group, Drivers of Ultrasound Use, a Retrospective Observational Study. Our presenter today, Dr. David Toro Tobon, is currently an assistant professor of medicine at the Mayo Clinic in Rochester and currently undergoing a master's degree in artificial intelligence as well in the Mayo Clinic. Dr. Toro Tobon is an emerging leader in the field of thyroidology with a unique focus on applying artificial intelligence to thyroid disease assessment and treatment. His research portfolio includes using natural language processing to analyze thyroid cancer data, exploring novel therapies for thyroid eye disease, and advancing redifferentiation therapy for metastatic thyroid cancer. Dr. Toro Tobon has been recognized for his contributions both national and at the national and international levels, with numerous presentations, publications, and leadership roles in medical education and training. To enrich today's discussion, we're honored to have Dr. Tobias Todsen as our discussant. Dr. Todsen is a head and neck surgeon and associate professor of the Rick Hospital in Copenhagen, Denmark. He is the president of the Danish Society of Diagnostic Ultrasound and leading authority in the surgeon-performed ultrasound and ultrasound-guided procedures. Dr. Todsen has spearheaded the development of European training recommendations for head and neck ultrasound and directs the Surgical Ultrasound Research Group in Copenhagen. With an impressive academic record with over 65 peer-reviewed publications and substantial competitive research funding, Dr. Todsen brings a wealth of experience to our session. Before we begin, I'd like to remind you, be sure to tune in to Voices of Wisdom, our podcast dedicated to medical professionals in thyroid cancer treatment. Each month, we explore expert insights and groundbreaking research. Catch the new episodes every third Tuesday of the month to stay ahead in our field. It's available in Apple Podcasts, Spotify, or your favorite podcast apps and platforms. Additionally, I would like to encourage all of our listeners to send in any questions that you might have throughout the presentation. And please feel free to submit your questions throughout the Q&A function. Without any further ado, David, the floor is yours.
Well, good morning, everyone. And again, thank you so much for having me. It's always a pleasure to be here talking about something that I know many of us are passionate about. This paper that was published about a year ago or within the last year, Drivers of Thyroid Ultrasound, Retrospective Observational Study. I am a consultant for Immunovant, but there's no conflicts related to this presentation. And again, this is a team effort. I'm just here representing our team, individuals that were in this study included Dr. Christian Soto Jacome, Dani Segura Torres, John Wee Fan, Andrea Garcia Bautista, Elizabeth Golembiewski, Mayra Duran, Ricardo Lord Torres, Nike Singh Ospina, and JP Brito. So a lot of individuals behind all of this work. And before we start talking about this, I just want to help you understand what's the relevance of this problem. So what you're seeing on this screen is 100 individuals. So think of 100 individuals. What do you think is the prevalence of a thyroid nodule? And it's going to depend. It's going to depend of the method of identification. It's going to depend of the population. If you go to the literature, there's going to be lots of different reports. But just a big estimate, if you go by studies that have reported pathology of normal thyroid glands, meaning individuals that by the time of death were not supposed to have any sort of thyroid disease, it's about half. So you can add to this those individuals that died having some sort of thyroid condition. If you go by thyroid ultrasound, these can go up to 70%. So quite a big number. If we're talking 7 out of 10, will have some sort of thyroid nodule. So extremely common. Odds are a lot of people that you interact with on a daily basis have a thyroid ultrasound, have a thyroid nodule if you do a thyroid ultrasound. So very, very common. And again, why is this a problem? Because if you take a look at the statistics and what has happened over the last 3 or 4 decades, this is data from the cancer registries in the United States. What we have seen is that the overall incidence of cancer has increased steadily over the last 2-3 decades. It has stabilized a little bit over the last couple of years, but the trend over the last 2 decades was towards increasing. If you take a look at adjusted by age, also same trend. But when you take a look at clinically significant cancers, meaning those that had significant morbidity and mortality, the trend didn't really change. So we're talking about a significant increase over the last 3 decades that was not associated with a change in clinically significant morbidity and mortality, meaning we were probably detecting many more that we should not be detecting. What changed over that period of time? Accessibility to imaging changed over that period of time. This was the big difference over that period of time. So that makes us think perhaps there is a problem. Perhaps there is something that we are doing differently that we shouldn't be doing, or that we should be doing more carefully, I would say. So what do we know about thyroid ultrasound, um, thyroid cancer overdiagnosis? We know it is a problem. We know there is thyroid ultrasound overuse that leads to thyroid cancer overdiagnosis. That is a well accepted concept. We know that there's small thyroid cancers that are more likely to be detected by thyroid ultrasound compared to other imaging modalities. We know, and when I say small thyroid cancers, I'm usually referring to those that are 1 centimeter up to 1.5 centimeters that are usually really benign course and do not tend to affect or lead to mortality in patients. We know that people that are living in regions that have higher rates of thyroid ultrasound are more likely to be diagnosed with these small thyroid cancers. And we know that thyroid ultrasound in patients that are asymptomatic can account for up to 25% of all diagnoses of thyroid cancer. So again, thyroid ultrasound overuse leads to thyroid cancer overdiagnosis. That's a big conclusion. We go back to the same question. Why is this important? Because there is a clear financial burden. Thyroid cancer has the highest rate of bankruptcy at 1 year of diagnosis in the US. And patients have increased morbidity from this. There's post-surgical complications. There's radioactive iodine-related morbidity and morbidity. And patients can have a decreased quality of life and overall sense of well-being can be affected. So this is not a diagnosis that we don't want to give to a patient if we don't have to. Big issue is, going back to our first slide, out of those 100 patients that we have, and out of those 70 patients that probably have a thyroid nodule, there's a big chunk that we might not need to identify. There's a big chunk that we um, might not need to do anything about, and maybe identifying might be causing some financial constraints, some patient-related constraints that we might need to tackle because there might be some downstream adverse consequences. The problem is, even though we know ultrasound is one of the main uh, issues or factors implicated in this overdiagnosis, understanding the reasons why we overused ultrasound or appropriately or inappropriately use ultrasound is extremely challenging because, as we're going to see in the next couple of slides, research on thyroid ultrasound relies on either big data that comes from diagnostic codes or billing registries or manual extraction of data. And it's extremely complicated to actually get this granular data on why are ultrasounds being ordered, what's the reasoning behind like all of these kind of overuse of ultrasound. So at large scale, it's really, really difficult to understand the problem. And if you don't understand the problem, it's going to be really difficult to implement the strategies to decrease this overuse to ultimately improve thyroid cancer overdiagnosis. So what we wanted to do with this study was to investigate the rationale behind thyroid ultrasound orders, to assess clinical outcomes post-thyroid ultrasound, and to determine the prevalence of potentially inappropriate thyroid ultrasound requests. This study was a retrospective observational study that we conducted here at the Mayo Clinic in Rochester. And it's important to note that this was specifically at Mayo Clinic Rochester in Minnesota. We have different sites within the US, and we have Mayo Clinic Health System, which is kind of like a community-based part of the Mayo Clinic, but this was specifically at Mayo Clinic Rochester, which is the main academic referral center in the US. This was conducted between January 2015 and September 2017. That's the time frame at which the patients presented to the institution. 5,938 patients were screened. They had their first thyroid ultrasound at that time, and out of those, a random cohort of 500 patients were selected. We reviewed their charts manually using a standardized format, and our annotators went through a calibration process to make sure that the annotation was consistent. They had a level of agreement that was superior to 80%. We reviewed demographics, comorbidities, ordering clinician characteristics, indications for thyroid ultrasounds, and outcomes after having their thyroid ultrasound. Continuous variables were evaluated with means and standard deviations, categorical variables, frequencies, and percentages. And we did conduct some exploratory descriptive analysis, including sub-analysis in populations that we consider of interest, including women, patients with severe conditions, and these severe conditions including elderly population, older than 70 years, or patients that have severe diseases that compromise their expected life expectancy within the following 10 years, or a specialty of ordering clinician. And before we go on and look into the results, I just want to clarify how we define some of the outcomes so that we are all on the same page. So how did we define the drivers of thyroid ultrasound? Symptoms. We define symptoms as any symptom that was related to a thyroid mass or a neck mass, including when a patient that was not necessarily symptomatic, but had a mass just present in the neck that they have felt and led them to consult to the clinic. And what I just want to clarify this concept because it can be a little bit confusing, meaning the patient maybe didn't have difficulty swallowing or the patient didn't really have fullness, but they just noted a presence of a mass. So they were not necessarily bothered by it, but they did notice the mass, and that was the reason for consult. So the mass was noted before consulting. The other indication was incidental finding on non-thyroid specific studies, screening, patients that had family history of thyroid cancer or hereditary syndromes that could be associated with thyroid cancer, routine physical exam of asymptomatic patients, and this includes patients in which that physical exam identified some sort of finding in the neck, including masses, including thyroid nodules, things like that. Now, the difference here, and that's why I wanted to make sure, is that these masses were not previously identified by the patient. These masses were identified by the clinician. Next, we have thyroid dysfunction, hypohyperthyroidism, without any suspicion for nodular disease, and also no concern for amiodarone-induced thyrotoxicosis. Then we have miscellaneous, just preoperative workup for hyperparathyroidism, or other sort of like surgical interventions. And finally, we have no reason found. Sometimes there was just no reason that we could identify. We also venture a little bit more and we define some categories of potentially inappropriate thyroid ultrasound. And I would say this framework was kind of defined of what can be guideline-based indications for thyroid ultrasound. This is based on recommendations from American Thyroid Association, European Thyroid Association. But again, there's not like universal indications for thyroid ultrasound. So this is kind of expert consensus. What we defined as potentially inappropriate was no reason for order what's being found, workup for hypo or hyperthyroidism with no suspicion for nodular disease or amiodarone-induced thyrotoxicosis, screening for thyroid nodule or thyroid cancer, excluding those instances in which there was family history of hereditary syndromes or thyroid cancer, or patient request without a clear indication for screening or thyroid ultrasound. So what did we find? Again, we had 500 participants. This was a random selection out of the patients that were screened within the study period. Most of our participants were female. It was around 65% female. The rest were male. We did have a predominance of white participants. It was more than 80%. The rest were Black or African American, and our participation of Hispanic Latino was very small, was less than 1%. The rest was a combination of Asian and other ethnicities. So this was predominantly white. Again, just to bring you back to our center, it was a single center, and it was third referral center. Types of ordering clinician, it was mostly attendings, 80%. So this was not trainees, this was not residents, fellows, this was practicing clinicians. A specialty of ordering clinician was more than 40%, 42, 45% primary care clinicians. Then we have non-endocrine specialists following. It was a little bit more than 30%, around 36, 38%. And finally, endocrinologists were around 20% in that order. And here we have the reasons for ordering these thyroid ultrasounds. The most common reason for ordering ultrasounds was actually incidental findings on unrelated imaging. This was close to 30%. It was followed by symptomatic neck masses. This was close to 20%. It was followed by findings after routine physical exam, and this was a little less than 20%, close to 18%. This was followed by evaluation of thyroid dysfunction, a little more than 10%. This was followed by miscellaneous, and finally screening and no reason. So the three most common, which accounted for around 70% of all the cases, were incident and findings of imaging, symptomatic neck masses, and routine findings after physical exam. Sorry, findings after routine physical exam. So some insights within these categories that we just saw. Preceding imaging techniques for incidental findings, 50% CT neck or chest, 25.6% PET-CT neck or chest. The most common symptoms included 44.1% self-identified neck mass, 25.5% neck fullness. Within the miscellaneous category, 52.4% was workup for hyperthyroidism. Within the screening category, 48.8% was family history of thyroid cancer or hereditary syndromes. 38.7% was done without an apparent reason. 12.9% was done just by patient request. And I just want to highlight this 38.7% without an apparent reason. It's quite high. And as I mentioned, we did do some analysis on populations that we consider of interest. This was defined a priori, including sex. What we can see here in this first side of the slides is female compared to male. The three most common reasons: incidental findings, routine findings after routine physical exam, and symptomatic patients. What we can see is that in females, it was more frequent to have thyroid ultrasounds after findings following routine physical exam and because of symptoms. It was not as common to have it because of incidental findings. Then in patients with severe comorbidities or older, it was much more common to have it following incidental findings. And then when we go by specialties, we have the exact same thing. fairly common to have it following incidental imaging. Routine physical exam, much more common in primary care and also symptomatic primary care. And interestingly, in endocrinology, it was much more common to have it for evaluation of hyperthyroidism, which was, I guess, a bit unexpected. So some things to keep in mind, because might be some actionable points here in deciding which populations to intervene in the future. In terms of appropriateness of thyroid ultrasound, what we deemed is that probably 1 out of 10 of the thyroid ultrasounds was likely inappropriate. And I just want to say that this was very kind of lenient with our criteria. We were kind of erring in the side of caution. And the causes for this likely inappropriateness were 39% just no indication reported, 32% functional thyroid disease with no concern for nodular disease or autoimmune amyloid-induced thyroid disease, 21.4% patient requests without a clear indication, 21% screening without family history or cancer or hereditary syndromes. So what happened? And I wanted to take a look at this graph. This is what happened from the moment that we had the indication for thyroid ultrasound all the way to the outcomes at the end after thyroid ultrasound. So as you can see, independent of whatever triggered the thyroid ultrasound, majority of the patients that actually have a thyroid ultrasound will have some sort of thyroid ultrasound finding. So again, we know that 70% of the patients have at least a thyroid nodule. So when you do a thyroid ultrasound, you're going to find something. Most patients had something. Out of those, when you see the fine needle aspiration biopsy, most didn't really need a biopsy, which is good. And finally, out of those, most patients didn't really end up having cancer or findings that were deemed to be bothersome or that needed follow-up. So in our cohort, only 14 patients had cancer. That was 2.8% out of the 500 patients that we included. No follow-up was needed in the great majority of patients. And just a little bit, this little bit chunk is the one that needed some sort of follow-up. So definitely seems like a big chunk of all of these patients that we have here probably didn't need that ultrasound for starters. I know we're going to have some time for discussion, and I want to make sure we have plenty of time, but there are some points that I want to highlight before we move into that discussion. There's some potential areas of intervention. Incidental thyroid abnormalities found on unrelated thyroid imaging are definitely one of the main drivers behind overuse of thyroid ultrasound. This is no secret. We have gained accessibility to thyroid to many imaging modalities over the last decades, and we have been able to identify many of these incidental findings of many other images. So many societies, including American College of Radiology, have proposed frameworks to try to decrease or try to identify in which patients do we need to do something when we find something in the thyroid, because as we notice, there is going to be something very frequently. So this is a framework that was proposed by the American College of Radiology. As you can see here, what they say is if you have findings that are suspicious on CT or MRI, then you just have to evaluate. But if you have findings that are not suspicious, then they kind of break it down. Is it someone that has life expectancy that is limited or that has severe comorbidities? Then do not do anything. Why is this important? Because, for example, as you saw, in our cohort, those that had severe comorbidities, elder than 70 years old, this was by far the main driver, and yet patients were still having thyroid ultrasound. So this could be, for instance, one of the actionable points where we could decrease thyroid ultrasound overuse. Then in general population, it's broken down by age. Age less than 35 years old, it goes by size. Depending on the size, you can decide further evaluation. Same age more than 35 goes by size. Depending on size, you can decide further evaluation. Again, these are kind of guidance. Sorry, these are not guidelines. These are just frameworks, white papers. So there's definitely more work to do here. And I don't think this can be taken as absolutes, but certainly things that need to evolve so that we understand how to move forward in a problem that is definitely a big issue. Now, the other issue that I find here is role of thyroid physical exam in asymptomatic patients, because we saw this is also top three. And the problem that we're finding here is that this is not a very sensitive test. This is results that you're seeing here in the screen are actually from a different study that we conducted in our group over the last 2 years as well. And this is evaluating the performance of physical exam for identifying solitary nodules and multinodular disease using physical exam. And what we found is that the performance is very suboptimal. So if you see on the screen, what you're going to notice is that there's really large variation in sensitivity and specificity across all specialties, including primary care providers and endocrinologists and other non-endocrine specialties. And if you remember from a couple of slides before, primary care providers, this was one of the main reasons behind ordering a thyroid ultrasound, was a finding after a physical exam. So this is important, and it's important because for many years now, the U.S. Preventive Task Force has actually recommended against uh, doing routine screening and thyroid physical exam in asymptomatic patients, yet we're still doing many things. So it's a challenge. It's a challenge because I understand, and many of us understand the value of physical exam as part of our interaction with the patient. Yet we need to figure out how to improve our practices so that we maximize the value of physical exam while minimizing the potential harms that we can create. Because one of the issues that we found in our study as well is that a lot of these times when these patients ended up being referred for thyroid ultrasound, something different was found. So we thought we were sending them to evaluate a right-sided thyroid nodule, and there was nothing in the right side, but there was something on the left side. Because again, 70% of the patients will have something, right? So it's a challenge. It's a challenge that needs to be tackled as well. What is the one of the main difficulties of our study? Again, it's very small. It was a random sample, tertiary care center, predominantly white cohort, so it's very difficult to generalize our results. And there is a lot of reliance on EHR documentation and reporting bias. Data in healthcare is difficult to analyze, is extremely challenging. There's a lot of levels of complexity in the EHR, the way data communicates in the EHR behind a scene is completely different to what we see on our computer. And truth is, the balance between a structured and unstructured data is completely skewed. Structured data is pretty much diagnostic codes, is pretty much what is used by most of the big data studies, what we use with claim data studies, what is being used by most of the registry studies. As unstructured data is what we use in most of our day-to-day, all the clinical notes, all of those radiology reports, all of these very nice and rich documentation that can give us all of this granularity is the unstructured data. In reality, that unstructured data is the 80%, the structured data is the 20%. However, for research purposes, we can only use that 20%. If we want to use the 80%, we need humans that can go and manually extract that data. That is impractical, that is expensive, that requires a lot of time. So what comes next and what our group is doing to overcome that challenge is actually leveraging artificial intelligence so that we can tackle this complexity. And we have actually developed a solution that based on what we have learned from this study that I just presented today and other associated studies, we have built some clinical domain expertise. We have built a set of rules that allowed us to build a computer system that reads through the notes and reads through that unstructured data, the clinical notes, the diagnostic reports, the ultrasound reports, and allowed us to identify which ultrasounds are deemed to be appropriately or inappropriately ordered. The importance of this is that now we're going to be able to automatically go from analyzing 500, 600 thyroid ultrasound reports with a human to automatically analyzing 18,000 thyroid ultrasounds with our automated system. This is not going to be only big data, but smart data. Our system was already validated and we're now doing the data analysis. So stay tuned. I think we're going to have more insights that will be useful and will give us a much more generalizable outlook of what's really happening in this area and help us tackle this problem in the future. So take home points. The overuse of thyroid ultrasound is diagnosed with overdiagnosis of thyroid cancer. Understanding why thyroid ultrasound is used or potentially misused is vital to prevent overdiagnosis of thyroid cancer. Thyroid ultrasound use was primarily driven by incidental findings on imaging, symptoms, and routine physical exam in asymptomatic patients. Most thyroid ultrasounds revealed at least one thyroid abnormality, and 1 out of 10 thyroid ultrasounds were classified as likely inappropriate. And with that, I will open some space for discussion with Dr. Todsen.
Thank you, David. This is an incredible presentation. We'll hand over the mic to Dr. Todsen for a little bit of discussion, and we'll come back for Q&A at the end.
Yeah, thank you. And thank you for the invitation to discuss this great paper. My name is Tobias. I'm from Retrospective Copenhagen, Denmark. And I have a patent for 3D ultrasound technology. Otherwise, I don't have any conflicts of interest. And this is a picture from where I'm coming from. This is our ENT department at the Retrospective in Copenhagen, Denmark. And I'll just shortly talk a little bit about our practice, because we have a setting where we have incorporated ultrasound as a part of our clinical examination. So we'll have the patient sitting in the chair, we're doing the ENT examination, and then we can go and do the ultrasound immediately afterwards. And we also do our own ultrasound guided biopsy if there's an indication. We see a lot of patients referred with suspicious of head and neck cancer and also thyroid cancer, and do all the surgery of the thyroid cancer for about 2.5 million. So we have a lot of ultrasound machine. Actually, in the ENT department, we have 20 ultrasound machines. We have integrated in all our outpatient clinical rooms, so we can do it as an extension of our clinical examination. We also have it in the operating room, in the ward, and we also have some handheld ultrasound machines for the medical students when they are going to get the ENT teaching and clinical training, so they can do their own ultrasound. And we're also having a lot of ultrasound research ongoing in the department. I have a research group working with this. And we're also training a lot of other ENT surgeons from other countries. We're having some international head and neck ultrasound courses. So we have trained more than 150 ENT surgeons from more than 30 different countries, and also working on some projects where we are providing ultrasound to resource limited settings together with the African Head and Neck Society, as using ultrasound as a cheap and portable image modality where there's not much other imaging modalities available. So with this background, I find it very interesting to discuss this great paper, because I'm using a lot of my time on teaching other people to use ultrasound and conduct their own head and neck ultrasound, and also doing research in improving ultrasound in ultrasound research to improve patient care. And this paper is focusing on the the need for limiting the use of thyroid ultrasound due to the overdiagnosis of thyroid diseases. And I think that is an important thing you need to consider when you're doing the ultrasound. In this presentation, I will start to discuss some strengths and weaknesses of the study, compare some of the findings to other studies, some implications for clinical practice, and some future research area. So a strength of the study is that it's, as I said, addressing a very relevant clinical problem, as David also described in his previous presentation. We see an increased use of image modalities in the healthcare sector, and due to that, we will also have more incidental finding of thyroid nodules, and we need to address that in the clinical setting. Another strength is this large sample size, 500 patient records. That's impressive. So congratulations with that. Compared to other studies, this is one of the biggest looking at thyroid ultrasound. There's another one with 572. Otherwise, it's one of the biggest studies within this area. And the authors also review the medical record 12 months after the thyroid ultrasound, and I really like that, so we can follow up what happened to the patients afterwards. So it's overall, it's a very well-written study and a high quality. There's also some limitations you can discuss. As David also mentioned, this is a retrospective study, and of course you could have some higher quality of data if you did it prospectively, recording all the information from the referral to the thyroid ultrasound. It is also, as David mentioned, academic center at the Mayo Clinic, a referral to radiology, and the data is taken from the radiology database from a period from 2015 to 2017. And so some of the data are now about 10 years old, and that is also a limitation. As you can see, this recent paper from actually last month, they looked at the thyroid nodule size on ultrasound, and they found that the size has increased from the 90s to today with about 0.5 millimeter a year. And the reason for that is probably that there's a more focus on the over-detection of thyroid nodules and a focus on only doing ultrasound of the significant nodules. Another limitation is that when they report the incidental findings on other imaging modalities, they only report referrals from MRI, CT, and PET-CT, but there's no referrals from ultrasound of other reasons. And as a clinician performing ultrasound on a daily basis for other reasons like lymph node, cervical glands, I see a lot of incidental thyroid nodules, and there must be some thyroid nodules found with ultrasound of other reasons, especially when ultrasound find these small nodules compared to other image modalities. And I would like some more information on what's happening with these ultrasound of other reasons. If we compare these findings to previously studies, then there's this systematic review from 2021, and they have a much higher frequency and inappropriate thyroid ultrasound reported. And I think that maybe also due to the, as David mentioned, there's not a clear definition of an inappropriate thyroid ultrasound. So in this study, it was reported that 11.2% of the thyroid ultrasound were ordered inappropriately. And the reason for that was, as David also mentioned, there was no clinical reasoning for the thyroid ultrasound. There was a dysfunction, thyroid gland function. The patient requested the thyroid without a clear indication or it was just performed as screening. I think all these things could be limited if we were more focusing on our traditional diagnostic paradigm, like taking a history for the patient, doing an examination, and based on this, we will order a test if it's necessary, and not the other way around, performing the thyroid ultrasound and then asking the questions afterwards, what would you do with these findings? So I think that's a great point. Also with this, we could use this study to focus more on our traditional diagnostic paradigm and decrease the use of imaging. Another thing that is very interesting is the use, and David also mentioned it, like the incidental findings on other imaging. It's actually tripled the amount of thyroid ultrasound due to this reason, and we can decrease the amount of thyroid ultrasound much more if we focus on this. And there was a reason, a paper in the beginning of the year looking at the additional imaging from head and neck examinations, and they found that 95% of the additional imaging referrals were based on the radiologist behavior rather than imaging variables that were measurable. So I think we need to focus more on the guidelines, and David also discussed this a little bit, like there's a high variability in when to refer these patients for a thyroid ultrasound, and we need to agree about which recommendations should be followed for the head and neck imaging examinations. And in the paper, and what David also described was this white paper from the American College of Radiologists. They have some guidelines, and I agree it's expert consensus, and we need actually some more evidence-based research looking into how to handle these incidental thyroid nodules found on other imaging modalities. And maybe we need to focus on raising the barrier when to perform an ultrasound of the thyroid, and then like comparing or making some cost effectiveness studies. Like we need to be aware that we may miss some thyroid cancers, but then we can decrease the overwhelming amount of thyroid ultrasound, and that's something we need to discuss, and also need to have some clinical studies looking into this so we can have some more evidence-based guidelines for these incidental findings on other image modalities. So that was some of my perspectives, and thank you very much for this invitation. I look forward for the discussion.
Thank you, Dr. Todsen, for your discussion. And I want to thank you both for giving us a little bit of your Friday to be here with us. I want to congratulate you both for your presentations. And I want to congratulate David and his group at the Mayo Clinic for this impressive work that you've put together. Not only this, but as you've mentioned, the background of a couple of other studies, as you previously referred to. I wanted to ask you a couple of things first myself, and I do want to encourage all of our listeners, if you do have questions or doubts, concerns, anything, please send them through the chat or Q&A function so we can address them before the end of the hour. In the study, David, you dissected the different drivers and you analyzed them between gender and between whom it might be that indicated the thyroid ultrasound in a moment. And you mentioned general practitioners, you mentioned endocrinologists. I did not see, however, surgeons or radiologists in that list. Did you have any granular information in that regard, or is it something that was just so small, the number was so small that we didn't account for it? Tell me a little bit more.
That's a good question. So the reason why it was not accounted for is because it's an ordering provider, and most of our orders are actually not placed by radiology. So that's why it was not differentiated. So the rare instances in which radiology was the ordering provider, they were just included in the non-endocrine specialists.
Correct. I see, Tobias, you raised your hand.
Yeah. I just have a follow-up question on that. Who performed? It's not clear who performed the ultrasound. These 500 ultrasounds. Was it attending radiologists or registrars, or is it sonographers performing the ultrasound? It was not clear for me the setting for these ultrasound performed.
Yeah, it's our setting here is actually mixed. Some of them is technicians, and then the interpretation is done by radiologists. Some of them is done directly by the radiologists, but we did not assess that difference in this particular study. So we did not really collect that data.
Okay, so with this follow-up question, it brings me to another point. This study is amazing. It's a very good sample size. However, it does not reflect what happens in the community, and you hinted toward this. It's a very academic, very high-level kind of institution research. How do you feel what this kind of data would reflect in the community healthcare services, where
Yeah,
you
absolutely.
maybe incomplete ultrasound reports, but you will have a little bit of a mix. And that's beautiful image that you were showing us from all of the drivers to what happens towards the end, like later down that history of that patient. How would that reflect? How do you feel that would reflect?
Absolutely. I feel this is one of the big challenges of this study is that this is a highly curated cohort. So uh, all of these patients had insurance or had some sort of access to medical care, and they were able to see things through all the way to the end. The other thing that we know here is that uh, they had, because they were at the clinic, they had access to other resources that might not be available in other centers, like e-consults or easy kind of like way to access kind of specialty kind of concepts or suggestions before ordering a thyroid ultrasound, for instance. So that might be one of the reasons why our rate of inappropriateness was a little lower than the 40% that has been reported in other studies. It is likely that if we go out in the community, the rate of inappropriateness is going to be much higher uh, because there might be more uncertainty about, well, I might err in the side of caution. I might just do it because I don't want to miss something, or I'm just not sure. So when I'm not sure, I might as well just do it because why not? So I do think in the community findings are likely going to be different, and that's one of the reasons why we want to expand, even though this is, and that's why even though this is a relatively large cohort compared to what has been reported, I still refer to it as a small cohort because I don't think it really reflects the reality of what is happening at the population level. So the hope with the system that we were able to develop is that we can actually apply it not only to our Mayo Clinic Rochester, but our health system that works at the community level and other health systems in different states in the country. So we can actually get a better picture of what's happening across the United States.
Very interesting. Tobias, you have a follow-up?
Sorry. I was just considering why you choose this. You randomly selected 500 cases out of a period of 2 years. Why did you choose this design instead of saying like, okay, we take the last 6 months or 1 year and just look at all the records?
It's just an exploratory analysis, to be honest, just based on data availability, because of how kind of curated the data was in the radiology repository, just based on data availability.
And how did you randomize it?
It was just kind of like a random allocation, simple random allocation, nothing fancy. Again, this was a very kind of exploratory analysis, so we did not do we were not trying to make sure that the sample was kind of well balanced in terms of like sex or age, or this was just a simple random selection.
Okay.
I see Dr. Margie Brown-Weber has her hand raised, and I don't know if that was a mistake or if she has a question. If you do, Dr. Brown, could you send it through the Q&A function so we could bring it up to the table? And before I lose my train of thought, the time question that Tobias was mentioning is very interesting, because would you ponder that the results would have been different if we would have done this in a different moment in time, perhaps now versus when it was performed? And I'm gonna explain why. In the past decade or so, there's been a trend of widespread use of ultrasound, as you mentioned, by not only radiologists, but endocrinologists, surgeons such as Tobias, and how he's spearheaded that in Europe, and another million different specialties that have started using ultrasound regularly. And also there's the coming of ablation, thermal ablation therapies for thyroid nodules. So do you think that with the trend of the use of these type of technologies, these drivers will change later in time? Also, between the study and now, that we had a COVID-19, which we cannot ignore. And do you think, or do you have information of how the trends or the drivers might have changed during that moment?
That's actually a really good insight. And I do think this is certainly evolving, and there's definitely more awareness in terms of overdiagnosis of thyroid cancer and overuse of these imaging modalities. In fact, what the data is showing is that the trend towards overdiagnosis is starting to plateau. We're not seeing that raise in the incidence anymore. So I do think some of these things are kind of plateauing. I think likely some of these things are changing, but I wouldn't be able to give you specific insights in terms of how much it has changed specifically over the last 5 years.
Correct. Tobias?
Yeah, it's just a follow-up question with you, Camilo. So do you, I agree with this, like you're referring, also there's some endocrinologists referring on probably for thyroid ultrasound, but do you think if they were doing their own ultrasound, they would decrease these unnecessary thyroid ultrasound? And yeah.
I don't know if it would decrease, but I think the driver would change, because as David elegantly showed, the reason why they were doing ultrasounds is a little bit different. There are some things that might some other specialties might oversee. For example, a general practitioner might not be as aware of, I don't know, amiodarone-induced thyroiditis, and the endocrinologist might be very aware of that in certain population. So they might have a different driver or a different need to use the ultrasound probe. I think it depends on the age group, the experience, the place in the world where you might be using them. So I think, and the time in life where we are evaluating this question, it's a really good question. And this is why I was kind of anxious to see a difference between not general practitioners or sonographers, but more so endocrinologists versus the surgical group, the head and neck group, to see if the drivers were different. And that would be very interesting for me, because it is a good question that you bring up. I'm not sure about it. I think the drivers will change, but I think there might still be a trend towards the overuse of the ultrasound. I personally don't like the word overdiagnosis, because it kind of has a bad connotation to it. And in the history of thyroid cancer, we tend to use words that have that kind of connotation less. You know, we introduce NIFT-P so patients don't see it as a cancer, and we try to soften those terms. Overdiagnosis has that kind of connotation, and I think other people might propose that it's a prompt diagnosis, and thyroid cancer has a different behavior from other cancers, so we're kind of swimming against the current, if I may. So I think overuse overall but I think the driver might be different, and I have no data to support what I am saying. Maybe David has a better sense of what that would look like.
I think that would be a phenomenal secondary analysis and try to understand if there's differences between surgical specialties, non-surgical specialties, because I do think there's probably going to be differences. I don't think our sample was big enough to do that analysis with ordering providers, but definitely something that we're hoping we can do with our next cohort once we have the big analysis.
I see a question in the chat that is very interesting, and I'm gonna try to put it to the end because Dr. Hua Chen from Mount Sinai is putting us in the spotlight. So we have ultrasound use, we have information that drives guideline creation, and we have guideline adoption. So he is asking, what is an indication for ordering an ultrasound? And I think that is a good question that we might not come to an answer in the next decade or so, but what are your thoughts? What would you say? Take home message, this is why you should do an ultrasound. David.
This is a very, very good question, and one that has been, I would say, quite difficult to answer. We, when we were trying to design our system to identify appropriateness, because again, there's not really a guide that tells you these are appropriate orders, these are inappropriate orders. It's challenging. It's challenging. So what we had to do was kind of design a framework based on when doing a thyroid ultrasound seems reasonable as part of the workup for. So what we're doing is, as part of the papers in which we use the term appropriateness or inappropriateness, we actually published a table in which we compile what we consider appropriate or inappropriate and the reasons why we consider that appropriate or inappropriate based on kind of which guidelines recommended using ultrasound in those occasions. But again, it's really challenging, and that's why in all of these occasions in which we use these terms, we err in the side of caution, and we try to be, if there's some doubt in which something could be appropriate or inappropriate, we just deem it appropriate, just in case,
Tobias,
for research purposes.
Sorry. Any closing remarks? What do you think is a good indication for thyroid ultrasound?
You're asking me? Sorry, Camilla. Yeah. But if you have a palpable mass, or you have some problems with your voice, hoarseness, and a palpable mass, or you can problem swallowing and like. So you have an indication of there is a risk of having a thyroid nodule that is significant. I think that is the most important reason to do the thyroid ultrasound. But we are doing a lot of thyroid ultrasound as a part of the neck ultrasound. So we are seeing, as head neck surgeons, a lot of thyroid nodules that we are not going into because you just have a small nodule in the salivary gland or something that is not connected to the thyroid gland. So I think it's an interesting thing with who's performing it, because if you're doing your ultrasound on your own, you also know that you're responsible for the patient, and when you're doing the ultrasound, you need to also make a decision for the patient. What is going to make? Are you going towards a needle biopsy, or are you saying this is just benign and don't worry about it? This is just an ordinary nodule that everyone has. You need to have the training and know how you will handle it if you do the ultrasound of the thyroid.
Correct. So a lot of work to still see, a lot of research that we need, and hoping to see the next steps in this field. I want to thank you again, both of you, for being here with us this Friday. I want to invite you next Friday for another Thyroid by MD's webinar session on ultrasound patterns and clinical parameters to inform probability of thyroid cancer predicted by molecular testing and nodules with intermediate cytology by Dr. Linwei Yip and discussion by Dr. Eric Alexander. Again, thank you both. Have an excellent Friday and stay safe.
Thank you for having us.
Thank you for being here.